So my name is Frey Hewitt. I'm the Acting Executive Director at the International Institute for Primary Healthcare in Ethiopia. So on behalf of the Institute, I would like to welcome you to our second webinar of the Urban PHC Tripartite Series, Challenges and Lessons, where we share different experiences from different countries. We have hosted the first webinar of this series in June 24 with the theme of characteristics of community health workers, and experts from Ethiopia, Bangladesh, and USA shared their experience with participants, and we had participants from different parts of the world registered and attended this webinar. So this webinar is organized by the International Institute for Primary Healthcare Ethiopia as part of our global PHC programs in collaboration with Johns Hopkins Bloomberg School of Public Health. And this webinar and our other global programs are expected to create a learning platform, experience sharing platform, and create an opportunity for South-to-South collaboration. This will help us cultivate learning and innovation. And today's theme is organization and management of service delivery. And we'll be able to see that in terms of urban primary health care with experts from different countries. So without further ado, I would like to call upon Dr. Rajani Ved, who has been coordinating and leading this webinar series from Johns Hopkins University side to say a few words about this webinar. So over to you, Dr. Rajani.
Thank you very much, Dr. Freywatt. A very warm welcome to all of you attending this webinar. This webinar series, as Dr. Freywatt said, is hosted by the International Institute of Primary Healthcare Ethiopia in collaboration with the Johns Hopkins Bloomberg School of Public Health. This is the second of a tripartite webinar series on primary healthcare in urban areas. Our first webinar that was held in June was focused on the role and contribution of community health workers to primary healthcare in three diverse contexts: Bangladesh, Ethiopia, and the United States. This second webinar focuses on an area of more recent study and interest, the organization and management of primary healthcare services in urban areas. Complex as the delivery of primary healthcare is in rural areas, in urban areas, this is even more challenging. Well-known challenges related to service delivery in urban areas across various contexts include rapidly growing informal settlements in urban areas, increasing population density, the problems of seasonal migration, population heterogeneity, the need to plan for population and geography-specific service delivery, especially for vulnerable populations such as migrants, the homeless, and street children. Urban populations are also highly mobile. In some districts of New Delhi, India, for instance, up to 40% of the population is made up of migrant populations constantly in a state of transition. Urban areas also have another challenge. They are characterized by a multiplicity of providers, government and private sector health facilities, as well as NGO-led service provision. They also have varying governance structures and an equally bewildering array of administrative structures and reporting relationships between municipalities, federal and district governments, and local government. So organizing in primary healthcare service delivery in urban areas requires attention to not just key components of the health system, but certain critical issues, and of course, many more will be surfaced by our panelists and our moderator. One of them is how do primary healthcare planners define a service catchment area in order to calculate population denominators for disease mapping and overall service planning. This is critical because it governs coverage and equity. How do you take into account the complexities of service use in urban areas where there's high access to specialist services, but a crying need for primary healthcare services, particularly public health functions? COVID has thrown up many challenges, and one of them pertinent to our discussion today is that public health functions, which are integral to primary health care, need to encompass all populations, no matter which income category they belong to and where they live. but government primary healthcare systems, which also deliver public health services, are often designed to serve the needs of the poor in urban slums. So how do planners organize primary healthcare and allocate resources so that public health functions are preserved while the interests of the poor and the marginalized in terms of service delivery are also safeguarded? We also have some notable success in primary healthcare in urban areas, but they are limited to selective primary healthcare, family planning, reproductive health, newborn health, perhaps. But what does it take in terms of human resources and financing to ensure equitable access to comprehensive primary healthcare? Our first webinar, which was held in June, was focused on community health workers in urban areas. This second webinar deals with issues of service delivery, organization, and management. And our third and final one, which will be held in August, will focus on the structures and processes of urban local governance that address issues of cross-sectoral convergence and the influence on primary health care. So the objective of our webinar series is to bring together learnings and best practices in urban health services from a variety of contexts in low and middle income countries to enable an improved understanding of urban primary healthcare challenges, identify opportunities for cross-learning and sharing, develop a research agenda, and really, with you all, build up a community of practice to enable a new stream of study and action related to urban health. We do hope you find this webinar informative and engaging and have an enjoyable experience today. So please do join us for our final webinar and stay engaged with this agenda. And now it's a pleasure to introduce to you all our distinguished moderator, Dr. Helen Schneider. Professor Schneider is a public health specialist and a health systems and policy researcher who has worked for more than 25 years on South Africa's health system. She joined the School of Public Health at the University of Western Cape in 2011 and was its director from 2013 to 2016. Since 2015, she's been the director of the University of Western Cape Medical Research Council Health Services to Systems Research Unit, and in 2016 was awarded a South African Research Chair in Health Systems Governance. Helen's research and policy interests have included an understanding of the political dynamics of AIDS policy in South Africa and the health system-wide implications of programmatic interventions such as antiretroviral treatment scale-up, the implementation of South Africa's ward-based outreach team strategy, governance and leadership of national community health worker programs, approaches to district health system strengthening and governance, and more recently, the governance of intersectoral action for health. Helen, over to you. Thank you all very much.
Thank you, Rajani, and thank you to the Institute and Johns Hopkins for inviting me to moderate this very exciting webinar and webinar series. It's my pleasure to introduce our panelists today and to give you a brief overview of how we will conduct this webinar today. So I'd like to start by introducing Dr. Irene Agyapong, who is in fact known to many of us. She is a preeminent health policy and systems researcher, thinker, educator. She's also a public health physician and has played leadership roles in the Ghanaian health system, on which, of course, she's an expert, as well as being an expert on West African health systems. And in her role as a leader manager, she was the regional director of health for the Greater Accra region of Ghana. She's also a founding member of the public health faculty of the Ghana College of Physicians and Surgeons. And importantly, she's currently the chief executive officer of a research program consortium called Community-Led Responsive and Effective Urban Health Systems, CHORUS, which is seeking to articulate and create understandings of urban health systems. So she is uniquely placed to speak to us today. Our second speaker is a future preeminent scholar, Dr. Anand Kultan Manuson, who is also a public health specialist, who has spent some time working in rural Thailand, as many young graduates do in Thailand. He recently got a master's degree in public health from King's College, London, and he has been studying health inequities in Thailand. He's currently a research fellow in health policy and systems at the International Health Policy Program in Thailand, which is a research institute under the Ministry of Public Health. And he's particularly interested in research on primary healthcare in urban settings, universal health coverage, health equity and access to health services. I think many of you would be familiar with the International Health Program, which has played a seminal role in knowledge generation in support of Thailand's many impressive reforms over the years. And I read an interesting description actually on the IHPP, which says that it is in close physical proximity to, but at an arm's length relationship with policymakers in and outside the Ministry of Health. So we are delighted to have these two panelists. The invite did indicate a third panelist, Dr. Rita Borit from Brazil, which would have formed an incredible complement to the focus on Ghana and Thailand. But unfortunately, a pressing competing commitment meant that she had to regretfully pull out. So we are going to focus today on Ghana and Thailand, two countries that have played major roles in advancing thinking globally, actually around universal health coverage, primary health care, outreach systems. And both countries have for decades been working consistently around health sector reforms to improve access and equity. So we think that we will have an excellent discussion today. The way we will proceed is I will invite first Dr. Anand to speak, followed by Irene. They will each speak for 15 minutes, and then we will open up for discussion. And that's where we would like you to participate. And we invite you to please post questions in the Q&A box so that we can engage the panelists in a masterclass actually on Ghana and Thailand today. So, and I'll also ask that all of you please just keep your mute buttons on and videos off while the speakers are speaking. So without further ado, I'm inviting you, Anand, to speak to us. Thank you.
Hello, can you hear me? And can you see my screen?
Yes, yes to both.
Okay.
Yeah.
Okay. Good morning, good afternoon, and good evening, everyone. I'm Anand from International Health Policy Program. Thank Dr. Helen for her warm introduction about my series, and I'm so appreciate the organizers who invite me to join this interesting webinar series. Today, I want to share some experience about primary health care in urban settings from Bangkok, Thailand. Okay. So this slide shows you a background of health system in Thailand. Thailand have universal health coverage policies with full population coverage. There are 3 health insurance schemes funded by the government. So most of health expenditures are funded by the government with small amount of out-of-pocket payment. We also have a comprehensive benefit package from prevention curative, rehabilitation, and primary and palliative care cover either simple diseases or rare disease or disease that needs like extensive intervention like cancers, hemodialysis. This all covered in our universal health coverage program. We also have a good distribution of healthcare infrastructure. You can see the figures um, um, on the right-hand side. There are primary care units in sub-district levels and secondary care hospital in district levels, and also tertiary care hospital in provincial levels. That make us can set up a referral system in every province in Thailand. And also, we also have 1 million village health volunteers who work for supporting health professionals to work in communities. This is a background of health system in Thailand, but the system in Bangkok or in urban area have a different figures. So today I gonna focus on Bangkok. When we say urban setting in Thailand, there are different contexts of urban settings. I divide into two types. The first thing is Bangkok, and another one is non-Bangkok, because Bangkok have very unique context, and it quite have, I think it have a very specific issue of concern. So today I gonna focus my presentation on about Bangkok's healthcare systems. As Bangkok is our capital city, is it our centers of Thai economies. People migrate from rural to Bangkok for their employment, for education. So the population density is high. This caused several problems with social determinant of health. For example, social inequities, housing problems, lack of urban green space, air pollution, traffic congestion, many problems about urban settings occur in Bangkok. So it makes a lot of challenge in our healthcare. And this slide focus about healthcare system in Bangkok. As I mentioned earlier, it very unique compared with other provinces. There is a greater level of healthcare resources in Bangkok. We have high hospital bed and health professional densities compared with rural areas. And the healthcare market in Bangkok have multi-payers. Compared with rural area, most of healthcare provider in rural area is under the Ministry of Health, but in Bangkok it's mix of public and private. So it make a difficulties of coordination. There are a lot, numerous private clinics, dental clinics, pharmacies, but few of them engage in service provision under public insurance. Although about financing, we have universal health coverage programs. It's covered whole population, but there are some challenges in Bangkok. For example, low utilization rate, higher out-of-pocket payment, and high unmet healthcare needs compared with rural areas. You can see the figures on the left-hand side. Bangkok had higher annual incidence of perceived unmet healthcare needs compared to other regions in Thailand. And in the right-hand side, the people in Bangkok suffer from undiagnosed and untreatment for diabetes than other regions. This can conclude that unmet healthcare needs is a big challenge in Bangkok. Focusing on primary healthcare, Bangkok lacked public primary care facilities, no healthcare functions in sub-district levels, no, on average, each health centers responsible for 120,000 populations in their catchment areas. The public health capacity also poor. For example, in the current pandemic situation, we cannot control the pandemic in Bangkok, but it is controllable in other rural areas where public health capacity is strong. For medical services, most of them are provided in hospitals. Only 1.7 million population registered in primary care. Other people registered in hospitals, and patients can use hospital for simple to complex diseases. This called overcrowded hospitals. And we also lack of communications and coordination between healthcare providers, leads to no effective referral systems. In terms of financing, all schemes cover curative care, but only universal coverage scheme fund for health promotions. We apply, and for payment mechanism, we apply mixed payment method for primary health care. For example, we have fee schedule with cost and budget. We have capitations, and we also have pay for performance for some activities. This slide shows you about private GP clinics under UC schemes in Bangkok. Because of insufficient primary healthcare provider in Bangkok, we engage private clinics in service provision under UC schemes. There are 2,004 clinics were responsible for 10,000 populations in each catchment area. Each clinic had one GP, one doctor, two nurses, 6 public health staff, and 1 part-time pharmacist. And every year, a clinic needs to be reviewed by public health centers, referral hospitals, and health security office for contact renewals. This can ensure performance and standard of clinics. However, there is no sufficient audit system. Last year, we have to terminate a contract with almost private clinic in Bangkok because of flood and fall claims. So we have to terminate and recruit a new clinic to join the UC scheme now. This table shows you a functions of primary healthcare providers. Public health center have more function. Public health center is under the local government. It have more functions. They can provide dental care, rehabilitation care, and public health functions. But for private clinic, they provide health promotion and prevention service. They provide ambulatory care, and they also provide community care or home care for long-term care something. So the function of public health center is more than private clinics. This slide shows you a new policy just implemented in Bangkok last years. We call it primary care network. After the termination of contact with cheating private clinics, we recruit a new clinics and implement primary care network policies. This covers around 1.7 million populations. Before we implement these policies, we found a problem that each clinic each provider works separately and no collaborations. So now we match primary care providers in the same area to work together. This includes private clinics, public health centers, dental clinics, pharmacy, nursing clinics. We also linked this network, this primary care network, to the referral health hospital as well. This policy aims to figure out the problems of referral systems and quality of care in primary care. Each provider have different roles. For example, private clinics, they provide outpatient care, they provide prevention and health promotion service, and they also provide community service. But for public health centers, they have a role of area managers, And they also provided basic service as them as clinic, but they have another role on public health functions. And they also have to supervise and coach private clinics on clinical practice or community work. And for referral hospitals, they provide secondary and tertiary care service for primary care provider in their network. And they also supervise and coach private clinics and public health centers about clinical guidelines, referral system, or something that relate to high-level care. About community engagement, that in Thailand we have health volunteers. In Bangkok, there are 15,000 health volunteers work with public health centers. They work to support health professionals about community health services, and local government provide small financial incentive for them. They can do anything that volunteer can do. For example, they can do a disease screening, they can do a disease control, they can help out us to help education for communication, and also do a home care or home visits. Another mechanism for community participation is local government health fund. This fund aims to support non-profit organizations for providing community health promotion programs. They are allowed 16 million US dollars budget per year, but it just implemented. The implementation is very slow, and we cannot see impact or outcomes of this fund now. To sum up, I think there are 4 challenges of primary healthcare in Bangkok. First, although we have a higher healthcare resources than rural areas, but we also face a problem about unmet healthcare needs in Bangkok. Second, poor health system governance. Second is a poor health system governance because of multiple healthcare payers, because of lack of coordination and no linkage between primary care and referral hospitals. And third, our primary care provider lack of capacities. I think it's due to insufficient investment on primary care. They have not enough budget, workforce, or not sufficient infrastructures. And the service system now is hospital focused, not a primary care focus in Bangkok. And last, there is a low level of community engagement compared with rural area. In rural area of Thailand, health volunteer and local government fund play a major role, a lot of role in primary healthcare. But in Bangkok, we can't see that situation in Bangkok. And I think to solve the problems of primary healthcare in Bangkok, we should do 3 things. Firstly, we should strengthen supply side capacities by increase numbers of primary health public health centers, increase engage more pharmacies and more dental clinics to support primary care work in urban areas. And we need to relocate contact from hospital to primary care. As I mentioned earlier, most of population in Bangkok register in hospital. We should relocate them to register in primary care. I think it would be a way to strengthen primary care providers. Second, we could increase capacities of primary public health center for lab on some function on some functions. For example, public health function and disease controls. Now we have a problem, a lot of problem about COVID pandemic, so we can control it. And we have very weak public health function in Bangkok. And for chronic care and home visit as well, it's a new challenge in Bangkok now, because we are in the elderly society, aging society. So we have a problem with chronic care and home visits. Primary health care, public health centers should increase their capacity on these issues. And lastly, I think we should increase community engagement. That should be a way to strengthen primary health care in Bangkok. So now that is the end of my presentation. Thank you for attention.
Thank you, Dr. Anand. Really fascinating. Loads of themes that we can pick up on, and really encourage those of you listening to post your follow-up questions. There's a lot to discuss about this, this contradiction between high concentration of workers and unmet need is really interesting, and how you're thinking about it. So Irene, over to you.
Okay. Thank you, Helen. I'm just sharing my screen. Okay. Hello. Good morning, everybody. Thank you again, Helen. Thank you, Rajani, for the introduction, and Arnold for the presentation. In fact, as I listened to you, I thought it's amazing how similar many of the issues are in urban areas across different contexts. I'm going to talk about urban primary health care in Ghana. I will not talk about everything. It's not possible in 15 minutes. What I've done is I've picked up issues which I think are relevant to the theme. So the first thing I will talk about is the issue of the context of urbanization. Traditionally, the focus of primary health care in low and middle income countries in Ghana and most of West Africa has been on rural health. Rural areas remain an important priority, but increasing urbanization is providing a dual challenge. And it's a dual challenge of almost extreme gradients that you don't see in rural areas. So these two pictures are both from the center of the city of Accra. The first picture is the part of the business district ministries area. Behind it are very attractive residential suburban living areas. The second picture is actually behind the business district of Accra. And here you have a squatter settlement of very poor migrants. And for me, these two pictures illustrate the challenges of urbanization, because they bring along with them different kinds of problems and risk. In the first picture type of context, you are struggling with some of the lifestyle associated diseases like obesity, sedentary lifestyles. In this one, you are struggling with rural poverty issues and now urban poverty issues. And in fact, I remember a survey we did, it's about 15 years ago now, it probably should be repeated, where we're just looking at nutritional indicators of children who lived in this inner city slum and other parts of the city, and there's still rural parts of Greater Accra. Sometimes we're finding worse nutritional indicators in the slums than in the rural areas. So again, this is just a bit of the context and the challenges it brings to thinking through what do you do. And this goes with what I've already said, where you can see that as the population of the country increases, you are getting increasing urbanization from about 20% urbanization at independence in 1960 to 51% at the last census in 2010. Because of the COVID-19, the 2020 census is now being started in 2021. I almost bet you will see even more urbanization, so that a lot of the people living in the poorer areas I talked about are actually rural urban migrants. And then you also have the traditional communities of the urban area. Okay. And you also have increasing prosperity. Poverty is reducing globally within the country. But then if you go to pockets, you still find there are pockets of poverty. So again, some of the gaps that I've just used these two pictures to illustrate, and the challenges that come with how do you address these gaps. Okay, so one of the issues I've picked at is governance and public participation, because if within the global data, you also have micro variations in indicators, how can you most effectively address these? The public sector in Ghana in health is administratively deconcentrated. You have a health service which has representation down to the sub-district and the community level. And then you have local government. And so you find that people working in the health sector in urban as well as rural areas have a dual responsibility and reporting relationships. They have the upward responsibility through the health service, and then they have the lateral responsibility to local government and communities. And it's recognized that this creates a tension between who the primary reference group of frontline service providers are. However, there is no conclusive evidence that a different decentralization model would give better results. It needs a natural experiment. And then you have issues about how to implement the community health services and planning model that was developed in poor rural communities and poor urban communities. Observation over time shows that, and it was interesting, it also came out in the presentation from Thailand, that community structures are different in urban areas. So community engagement then poses a different kind of challenge. And I think one of our problems now is we don't sufficiently understand how to deal with that challenge. So for example, in one research work that we are still doing now about urban community-based health planning and services, as part of the, trying to understand the urban community, you are finding that and I'm talking of a small locality of maybe 5,000 to 10,000 people, but a poor locality. You are finding that it's multi-ethnic, it's multilinguistic, you have floating populations. People are here today, they are not there the day after, they come for a month, they move on somewhere else. So you don't have that kind of cohesion that you have in rural areas where people are where they've always been sometimes, and their parents and their grandparents were. So you really need to think, but how do people cohese and help each other and engage here? And then you find that you need to think through different structures like trade associations, like associations of people within mosques and churches, within ethnic. So these are just examples to show the different challenge of trying to understand how to actively engage urban communities where the social capital is and how to work with it. And then the other thing is geographic access. In rural areas, the geographic access problem is often how to get there. In the urban areas, what we are finding is that actually, because of public transport in Ghana is actually private transport. It's interesting, but it's organized by the Private Road Transport Unions Association, but they have a really good network. So even though in urban area, this is from work in 2011, looking at how people go to their usual place of care. In 50 minutes, I don't present all the data, but all these people say I can get there within half an hour. But basically, they can't get into public transport, they can't walk and so on for their usual place of primary care. The problem sometimes is when people are on a low wage, even the jumping into public transport and paying the fare becomes a problem. In rural area, the problem may be there is no public transport. So again, you need to think through the issues differently. And then the other thing is, what kind of care are these people using? And again, it's a pluralistic medical setting. You have the public sector, you have the private sector, you have alternative providers, you have what we have called pharmacies are actually include over-the-counter medicine sellers. So again, we found that people actually generally are still using the public sector, and especially in the poorer localities. But you are also getting quite a large use of the private sector and over-the-counter sellers of medicines and so on. So again, in thinking through how service delivery in the urban context, you need to pay attention to the private sector. If I showed the same graphs for the rural areas, the private sector would literally disappear, and you might not see so many pharmacies and over-the-counter sellers of medicines. What you might get are informal providers. Okay. And the other observation, and again, it may vary from country to country, is that part of it may be because of the access, is that a lot of in the urban area, this includes the urban poor, as well as the middle and the upper class, even when primary care is available, they are tending to use hospital OPDs for their primary care. And they are using a lot of the public sector though, which is a good thing. But the question is, how do you get people in urban areas to have the confidence in their primary care and not congest hospital OPDs? And how do you better engage the large private sector in this delivery? Urban PHC financing in Ghana is not different from the rural. And so the sources of funding are the government taxes, out-of-pocket fees. Then our national health insurance is about 70% funded by a value-added tax, and then about 25% by social security contributions of people in the formal sector, and 5% by out-of-pocket premiums. So, and the funding is all centrally pooled and controlled. So to that extent, the funding is equitable. The inequity comes in the fact that you have to register to benefit from the scheme. And in fact, if you look at this graph, which goes from the start of the scheme started in 2004, the data is available from 2005. You can see a peaking of the percentage of the number of the population who is registered at about 40%. Ghana now has a population of about 30 million. So there is an inequity going on in that even though the fund is central and in theory equitable, only about half the population, and that applies to the urban poor as well, actually has access to this scheme. And in fact, sometimes you're even having less people registered in urban areas than in rural areas. Some of it is a function of the migration in and out and so on. Okay. So from all I've said, what are the areas for future research? I think it came out in what I was saying, that we really need to pay more attention to this issue of gaining a better understanding of how urban communities, especially the poorest communities who are often the most vulnerable, organize socially, support each other and engage in health. They do organize, like I said, if you take the work we've been doing in the inner city, for the community-based health planning and services, you have several very well organized associations, but they are organizing by something else other than where they live. And then what are urban community concepts, perspectives, and definitions of poverty and vulnerability? And how does it affect how you reach, actively engage, and equitably increase visibility, voice, and participation in urban health? And then there's this issue of the increasing non-communicable disease burden alongside it's a mistake, it's NCD, not CD, alongside the already existing burden of communicable diseases, and how do you provide access to care? I don't show the data because, again, for time, I try to control how much I put on these slides. But for example, if you look at the National Health Insurance Scheme data, a major driver of medicines costs is actually medicines for hypertension, for example. It's clearly a problem. If you look at the data, those kind of problems are much higher in urban than in rural areas. And then understanding the social determinants of health in urban areas, and how do you engage local government in cities for the health of the population? Thank you very much.
Excellent, Irene. Really another absolutely fascinating presentation. So, yeah, so we are starting to have quite a lot of questions coming through on, firstly, well, I think mostly on Anand's presentation. I think the ones linked to Irene's will start to come in. So thank you for posting those. And they're really asking, I think, the questions to provide a further clarification on some of the themes. A key one is the question of governance and stewardship. Both the horizontal coordination that's required between these multiple providers, plural systems, and I know you put that primary healthcare center there at the middle of it. Does that stewardship function exist at that level? You spoke about the sub-district healthcare function not being sufficiently strong. And so, I mean, could what is the thinking around systems of governance and stewardship, and the forms of governance that are much more network forms of governance than hierarchical forms of governance? How are you thinking about the structures and processes of governance and stewardship? And then, Irene, you could pick up on that as well. So how, what is the unit of oversight of managing the sort of vertical relationships, the referral, gatekeeping? How do you organize that function, particularly in these large metros? So we have that here as well. The political structure is the metro, which is much too big as a governance unit. So you need a sub-district, a sub-metro system of organization. And what are the emerging forms in Ghana? How are you thinking about the governance and stewardship question at a more granular level, at a more local level, that can begin to create these systems of coordination, accountability, but also contracting? So these, interesting in Thailand, these accredited, private providers, how are you bringing them into the system? Where's the oversight and monitoring of that happening? So it's a question, if you could both talk a bit more about the governance stewardship function, and I'll start with you, Anand.
Thank you, Helen, for the questions. In Bangkok, as I mentioned earlier, that there is a problem of health system governance. Many cause of this problem. I think first thing is like there are multiple healthcare players in Bangkok. Compared to rural areas, most of healthcare players in rural areas is under the Ministry of Health. But in Bangkok, we have both public and private sectors play a role in healthcare systems. And among the public sectors, we also have a different organizations. Some providers are under the local government. Some providers are under the Ministry of Health. Some providers are under the universities, or some providers are under the military. So this makes the confusion in our in health system in Bangkok, as each sectors have like its independencies. So they lack of coordination. I think local government should we should promote the role of Bangkok local government to be a health system managers or to be a health system leaders. The health system development in Bangkok is no direction. I think if we have leaders, if we have like a health system manager who authorize for governing health system in Bangkok, I think it should be better than now. That's all my questions.
Mhm. Okay. Thank you. You asked me to also comment on this issue of governance and stewardship, and I wanted to pick up the issue of oversight for managing referrals, gatekeepings, etc., in metro and sub-metro. It is an important question. I'm afraid at this point in time, what I can tell you about is what we are struggling with. We don't seem to have found answers. In fact, it's acquired a name called the no bed syndrome, and it's an issue which has, it's some periodically to make front page of newspapers. There's even been a whole parliamentary committee on it, but nobody seems to be able to resolve it. The fact is that despite the plurality of service providers, public, private, the coordination is weak. And when it comes to referral, there's a challenge, because what happens is a lot of the referrals are done to specific hospitals. Often they are in the public sector, they are tertiary level hospitals who work 24 hours and so on. And they have limited bed space, they have limited human resource. So what happens, and then because there's no coordination, what happens is a peripheral clinic sees a case and decides go to hospital X, but hospital X is full. Their emergency beds are full. And so hospital X doesn't even receive the case. They kind of pass the case on and say, try hospital Y. And I'm sorry to say, people have died going around the city in cars and taxis and ambulances, just looking for a hospital that can receive them. A couple of years ago, we tried on a pilot scale, a call center to coordinate referrals among a group of hospitals. It worked for a while, but it founded on the problem of resources. And it's all the resources to keep the call center going, because there is a background cost of managing such an intervention. So that's what I would say here, that it is a major weakness for which a solution needs to be found. And similarly, the referral systems are not working. I mentioned the fact that you are seeing people using the outpatients departments of hospitals and emergency rooms for primary care rather than going to primary care centers. So not enough insights to offer at this stage, but rather to flag it as a very important area that needs more work. And it will be interesting to hear about the experience from other cities. And I may also add that related to this experience is that because of traffic congestion, now we have an ambulance system. You don't have enough ambulances, and you have had cases of people struggling in a taxi with a very sick patient through traffic, and sometimes they're not getting there on time. So it's a bit of a mess.
Excellent, thank you both. So some more difficult questions coming your way. So it's several questions related to issues of community engagement and how one thinks of it in urban areas. And I'm just going to read some of them. Irene wanted from Asuma Mamdani. Irene, do you have any insights to social accountability initiatives in urban Ghana, if there are, and empowerment of urban communities with attention to marginalized urban communities, and how the health systems actors respond to such initiatives? So you've started to speak to some of the emerging forms, but maybe you could tell us a little bit more. And then Ute Lehmann it would be interesting to hear both panelists comment on the issue of heterogeneity of urban communities and its impact on government's ability and willingness to engage with community structures and organizations, i.e. the most legitimate community structures may not always be the ones that are formally legislated. So how one works with what, collective action emerges from community and what are the designated structures of community participation and accountability. There was, let me just see, there were a few. So there was, could you say, Anand, say something more about the reasons for low community engagement in Bangkok and how you will go about increasing this, which I think is the same set of ideas and questions. So Irene, why don't you start by just telling us a little bit more about that, and then Anand, you can follow.
Okay, thank you, Helen. Actually, I'm not sure we have enough insights about social accountability initiatives in urban Ghana. In fact, that's why I mentioned that I'm currently part of a research group in the Ghana College of Physicians and Surgeons, trying to understand some of these issues and how they would affect how you want to organize urban chips. I can speak from more casual observation, and that is that basically in urban areas, it looks like people are organizing around trade organizations. So for example, if I have hairdressers association, taxi drivers association, truck pushers association, head porters association, and within these associations, they seem to have a lot of accountability to each other. You'll find they maybe have a secretary, a treasurer, a chair, they pay dues, they support each other with social events like funerals or sickness and so on. But it really needs a better study and a better understanding of these ways of organizing in urban settings to be able to know whether you can use the way people are organizing to help organize for health. So I'm afraid my knowledge is limited at this time, and we are still trying to understand the issue. And it affects governance and participation because in theory, the community-based health planning and services system is supposed to encourage community participation and engagement. In practice, you are finding that community participation and engagement is weak. And again, it comes back to these questions. So that's what I would say at this time.
And for my question is about community engagement. I think in Bangkok we have very low community engagement compared to rural areas. I think it's caused by if you recognize my presentation, in Thailand we have 1 million village health volunteers, but in Bangkok we have only 15,000 village health volunteers. So I think in Bangkok the number of village health volunteers is very low compared to the population in Bangkok. Another thing, I think if we want to make more engaged from communities, I think we should strengthen them. As I mentioned, there are local government health fund that we're gonna fund it for non-profit organization to set up the program for health promotion or health prevention, disease prevention. But now it is spend very few amount of budget because most of non-profit organizations, I think they don't have like they don't have capacity to propose a program or a proposal for submit for budget, I think first thing we should strengthen them to understand the health problems in their community and to seek a way to solve the problem in their communities. And I think it's gonna be better. We can engage them for the long term.
Thank you. And it would be interesting to know more about that that fund that is seeking to strengthen the sector. Okay, so another question for you both. So around the question of providing services to mobile populations, people who move around a lot, particularly ensuring continuity of care, any emerging experience around how you work with that? Perhaps it's a related question. So here in South Africa, we increasingly talk about differentiated models of care. It's an idea that's emerging particularly from the field of HIV. Actually, it's come from innovations in community clubs, community-based distribution, alternative forms of delivery outside the health facility that rely on self-management, peer support groups, et cetera, So perhaps you could talk a little bit about emerging or any experiences with new forms of new models of delivery that, for example, cater for highly mobile populations, and any other insights you have about managing the complexity of urban healthcare. So, Irene, would you start?
Okay, thank you, Helen. Yeah, that's a really important question because the mobility issue is really difficult. And it's actually an urban as well as a rural problem because sometimes the floating population in urban areas are actually a rural population. They migrate seasonally. In fact, you find people are migrating to look for seasonal work and then migrating back. Sometimes they are even taking their families with them, leaving their families back. One of the things I noticed that the questioner asked about mobile records. That is being tried. In fact, currently women are allowed to carry their maternity record books home with them and back again and take them with them wherever they go. The advantage of that is that the record is kept by the woman and moves with the woman. The disadvantage is that depending on their understanding and how careful they are, you may lose the records. And I think some clinics are trying to keep a duplicate in their system. I think also the way forward, and it's always a challenge in resource-constrained settings, is to have a computerized and networked system so that when a patient presents in a particular, especially where you have a national health insurance system, you can access the records through the system with the patient's unique ID number. I think really that's the only way around that problem, because the other social problem, at least in a country like Ghana, I know what other countries do, is that people often have multiple names. So everybody has a day name. It's a name which identifies the day of the week you were born on and what your gender. It's a given. And then everybody may have a first name and a second name and a surname. And what happens is that sometimes people present at one clinic with their day name, they present at another clinic with their first name, they present, even at the same clinic, they may do that. And you can find multiple folders. It's a really difficult problem. It would be interesting to hear what other countries' experience are in this thing. But my recommendation would be, difficult as it is, we need to computerize systems and network systems, and also encourage people to be tied to a preferred primary care provider. In fact, one of the reforms we tried to do in Ghana under the capitation system, which has now been put on ice for a variety of reasons. It's a whole story in itself, to tie people to a preferred primary care provider for whom they have to go to and the preferred primary care provider is not necessarily one clinic, it's a network of clinics. They have to go there for their primary care and and be referred from there to the next level as a way of trying to keep people as a whole and not have them fragmented and lost in the system. Thanks.
Before Anand speaks to this, a very specific question, Irene. Can you describe what the old method and new method of registration are? What's the difference? Yeah.
Yeah, sorry, I was going to type an answer. I think I clicked the wrong button. No, it's actually a population denominator issue. There was a lot of political pressure for the district schemes and the mutuals to demonstrate that they were equitably covering all Ghanaians. So people tended to use a cumulative record of who is registered in the scheme rather than adjusting for annual changes, because some people drop off and are no longer registered. When that error was found, it was corrected. I kept it there because I thought it's also an interesting example of how the way in which you present data can change the impression you give depending on the incentives that are being made as to how you present your data.
Thank you. Okay, Anand, over to you.
For me, I think I agree with Eileen that the next, if we want to strengthen primary healthcare, the first thing we should do is health data side. Health data, personal health record is quite important because in urban settings, people in urban areas mobilize a lot, and they have a lot of choice of to use the healthcare system. So I think if we have personal health record that every provider can access the data, it should be good for continuity of care. Another thing, I think we should gain more access by involve more health professionals or healthcare providers. For example, in Bangkok now we have only 200 clinics. We should involve other kinds of healthcare providers. For example, pharmacies, dental clinic. I think if people have more choice, they can access to healthcare, and their health would be better.
So there was another specific question. I don't know if you saw it, Anand, but so the ratio of one health center for 120,000 obviously is huge. And, you know, what does that mean in terms of geographical access? And what is the ideal ratio? Are they very big facilities? Yeah, tell us a bit more. Yeah.
As I mentioned, in Bangkok, we lack of healthcare facility in sub-district levels, but in rural area, we have health centers in every sub-district. So in Bangkok, public health centers, we have only 69 public health centers. So on average, 120,000 population per one public health centers. But we try a lot to involve private clinics to provide services for people under the UC scheme. So this is a way that we solve this problem. And another thing, as I mentioned earlier, in Bangkok, we don't our health service system is hospital focused. So most of people can directly go to hospitals and get a service. And another thing, most of in Bangkok we have a lot of clinics or pharmacies or dental clinic that not engage in UC scheme. So some people can access that and as a supplementary healthcare. So they pay out of pocket payment for that type of providers.
Okay, perfect. Thanks, Anand. So the one of the questions from Yeubda Hirpa is about saying that in Ethiopia the greatest challenge is multi-sectoral coordination, and that is the theme of the next webinar. So we're not going to make this a major theme today, and you should all join you should all join the next webinar to talk much more about this. But anything either of you want to briefly say about experiences with others, collaborating with other sectors in urban areas in your two settings? So Anand, do you want to start with that, or Irene? Okay, Anand's still looking at the questions. Irene, why don't you go? Yeah.
Okay. Yes, again, another very important question. I think really effective multi-sectoral collaboration requires local government engagement, and it requires both formal and informal engagement and a recognition that it matters. If I can use very personal examples, I spent years as a district director of health and several years as a regional director of health. Because the health service is administratively decentralized, it's easy to keep reporting up the line and supervising down the line and forget these lateral relationships. But they are incredibly important because it's at the district level, for example, it's within the district assembly, which is the local government assembly that involves the heads of the decentralized departments are invited to these meetings as ex officio members. The community representatives are there, the members of parliament are there, the executive are there. It's engaging in these kind of meetings that you begin to hear issues from other perspectives, and you are also able to table your issues. And often in the health sector, we are so busy with our issues, to invest time in such a meeting may almost seem like a waste of time. But I found that it is not a waste of time to engage in these meetings. And very practically, I think for people who work in the health sector, intersectoral collaboration requires a rethink of allocating some of your time to local government engagement. And it's also a give and take matter. If I can give another example, which seems off, at the regional level, for example, the local government equivalent is the Regional Coordinating Council, which has, as I said, the regional minister. I'm sure in every country you have the equivalent. And there were several committees. One of them was the Tender Review Committee. Now, that sounds incredibly dry and boring, but all the heads of the decentralized departments have to be present at those committee meetings to present whatever tenders in that sector need to be reviewed. And over time, you realize that actually a decision as to where to build the new road, a decision as to where to put the new school, what kind of school, and even the engagement with these heads is all part of strengthening intersectoral collaboration. So to cut a long answer short, my suggestion for multi-sectoral collaboration is a practical hands-on engagement at the local government level and recognizing it's a give and take matter. When the people taking decisions on where to place the new road, you can't be bothered to sit in their 2-hour meeting because it's roads and you are busy. When you want them to sit in your 2-hour meeting to discuss the health needs of the most vulnerable, they are also too busy. So it's a very practical, hands-on kind of thing, and a thinking through a give and take, trust, relationships, accountability.
Fantastic, thank you. Anand?
For me, I agree with Irene that local government should be a good portal for multi-sectoral collaboration because because local authorities don't take care only health issue, but they they provide many services like education, transportation, environment, everything about people life take care by local government. So local government should be a good portal for multi-sectoral engagement. Another thing, I think healthcare providers also need some skills. We should strengthen their capacity to engage with other sectors. I'm not sure, but I'm not sure which kind of skill, but I think when we communicate with other people outside our field, we need more like more communication skill. We need to engage them quickly or anything else. Um, and lastly, I think trust, we need to build up trust between sectors. It's quite important because if we have a common goal, we trust each other, we can set a common agenda and we can do a program for health promotion or do anything about health together. I think trust is a, a, a thing that we need to build up.
Okay, Rajini wants to say something. Yeah.
I'm sorry, I can't type into the Q&A. I can't understand why, but I have a question for both panelists. In COVID, we found that when it was important to do contact tracing and surveillance in more affluent households where typically government primary health services or facilities don't exist, we had a huge problem. We didn't have community health workers in those affluent areas. We didn't have enough service delivery sites, and therefore to mount contact tracing and surveillance in those areas became really difficult. So I'd like to hear from you both what your experiences with providing public health, essential public health functions in better off areas beyond the basic water and sanitation is, and how does one look at these issues? Because in a sense, we needed to democratize this much more, but we were not able to. Thank you. Over.
So, Irene, you unmuted. Are you getting ready to respond?
Yeah. No, I was just nodding because I think it's a really great question, and yes, and in fact that's why I actually prefer the term inequity to inequality, because an inequality can be equitable, and an inequality can be inequitable. And I think sometimes it's a really important issue about this interdependency in urban areas. Sometimes for the public health issues, there are some issues where you realize that how to now reach the better off in urban areas is a difficulty. Even home visiting, the better off neighborhoods in Accra are walled. You have to knock on a door. There may be a sign which says, beware dangerous dog and things like that. So you find people may skirt these kind of neighborhoods. It's okay for some things, but when you have something like COVID that doesn't care about a neighborhood, you can have a challenge with. But having said that, I also think it's a matter of, again, understanding and teaching people to understand communities and how to reach out to them, because sometimes, and understanding also how urban communities organize and how to work with this organization. And another thing which didn't come out, which I want to raise, is that actually I've observed in Accra that you actually have pockets of poverty within fairly wealthy suburban neighborhoods, because what happens is you can have people living, somebody hasn't finished building a house and they ask, can you look after this place for me? And somebody is living in a wooden kiosk on the compound of the house, and they are really desperately poor, but they are lost because everybody has labels that geographic area as affluent and doesn't bother to take primary care there. So I think it's a great question, and we really need to kind of be careful about in our efforts to be equitable, forgetting the fact that sometimes problems are not necessarily linked only to the poorest of the poor, that the problems can move across. It can be quite difficult knowing where to draw the line.
Great. Anant, your Do you want to weigh in here? Yeah.
In Bangkok, public health center haven't done good on public health function or surveillance under the COVID pandemic. We have a lot of outbreaks in communities. But one thing I learned from COVID is community can support them together. Community can support each other together. We have a cluster of COVID patients in one slum or one congested communities. And after that, they set up the community isolation to isolate people who infected with COVID. And after that, after they set up these isolation areas, we can control it for a while, not now, because now the third wave it come back. But I think people in community have capacity, and we should literate them and strengthen their capacity so we can combat with public health pandemics now. Okay, that's all of my answers.
Yeah. Okay. So, all right. So we're now at 9 minutes to, so I'm going to ask one more round of questions. You both in that last round touched on the equity issue, which obviously is a huge question in urban areas, how to characterize it and how to address it and monitor it. So perhaps I could then ask a last set of questions related to staffing, people, human resource mix, who are the key players in these services? So we've touched on community health workers, but can you say something about, more complex staff mix emerging in South Africa? The cadre of pharmacy assistant, for example, has emerged in the last 20 years, and in every single primary healthcare facility you have one now. A data capturer is another one, related to these new long-term care burdens, HIV, TB, NCDs. So it's about the kind of the emerging ideas around the staff mix in urban primary healthcare systems related to efficiency and complexity. Okay. A second question relates to the preparation of managers and leaders at the local level. So, you spoke, Irene, and Anant, about new mindsets and abilities to engage, to work at an informal level, to be willing to consider reciprocity rather than command and control. Okay, so we're looking at new forms of relationship. How do you prepare frontline managers and leaders to navigate this world and to navigate complexity? So that's a second question. And then the last question. So one of the big themes and discussions actually that emerged in COVID-19 here was the issue of staff wellness, well-being of frontline staff who were bearing the brunt of the COVID epidemic, and just, how tough it was for them, and a reevaluation, a recognition of frontline staff and their mental health and well-being. So anything you want to say about any of those, and then we'll ask you perhaps after that just to make any last final comments. So Anant, do you want to start maybe?
About skill mix, in Thailand we have many experience of skill mix, but most of these skill mix are in like rural area. For example, we have dental assistants, we have dental nurses, and we also have like pharmacy assistants. I think this concept should be a good idea for like solve the problem of lack of staff, lack of healthcare professionals. But the key thing is we should like have one thing I found when I was at hospital directors in rural hospitals, I found that the like career path of this type of skill mixed staff like dental nurses, they don't have a good career path. I think we should like strengthen them and build up their career path and promote them to be more like more 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 education. Like we some hospitals grant scholarship for dental nurses to study in dental school to be dentist. I think this should be good for skill mix professionals. But in Bangkok, I don't see a skill mix in primary healthcare in Bangkok because we use like nurses, we use doctors and public health staff and pharmacists in private clinic. And in public health center, we also have full kinds of staff in Bangkok. So it's not an issue in Bangkok, I think.
Maybe I could just, sorry, let me just give Irene a chance to chip in there. I'll come back to you. Yeah, Irene, anything you?
Maybe I'll just, I'm looking at the time. Let me just pick up the frontline health worker issue and the staffing mix. And I want to throw into there some thoughts around workload, because again, my experience working in the Greater Accra region was that you would go for national meetings and they would say there are 1,000 doctors in Greater Accra and there are only 20 in Upper West. This is inequitable. We need to move some of the doctors from Greater Accra to Upper West. And the question would be, what are the workloads in Upper West? What is the population in Upper West? And there's also the mix. And then within Greater Accra, how are these doctors distributed? In fact, and back then when you did the analysis, of the 1,000 doctors, about 500 were in the teaching hospital. Of the remaining 500, another 200 were in the military hospital. And of the remaining 300, I think another 100 were in the police. The long and short is by the time you got down to which of these, I'm only using doctors because of the time, which of these doctors are actually out there in the front lines, delivering more primary care needs to the 4 million people, you find actually it's not as great as it looks. So my comment would be that part of the research agenda going forward is to do a more nuanced analysis on some of these issues of staffing numbers and staffing mix and link it to a workload analysis, and also to within urban areas themselves, a bit of an equity analysis and distribution of staff with very careful qualitative thinking, because when you engage the teaching hospital, they would also tell you, but then all the complicated cases are sent to us. And some of these large doctors' numbers are people we are training. So if you think you can take them away to go and deliver service somewhere else, who will train them there? So in a way, I haven't answered your question, but I'm just adding something to the research agenda. Yeah, of a more...
Yeah, no, you have. And I'm sorry to have cut you both. So I think we are now reaching the end, and we filled up the time magnificently. So I want to just thank you both for a really, really interesting conversation. Really pleased this is being recorded, and hopefully will be the start of many other conversations. So a big thank you to you both. And I just wanted to, before we close, remind everybody of the next seminar, which is on Thursday, the 26th of August at the same time. So it's 2:30 East African time. And the title of it is The Role of Urban Local Governments in Addressing Multi-Sectoral Convergence for Primary Healthcare. We'll have inputs from Cuba, South Africa, and India. So promises to be very exciting. So with that, I would like to thank all the participants for joining, all your great questions, and the 83 of you who stayed right till the end. So have a wonderful afternoon and goodbye.
Okay, bye-bye.